And greetings from UK to all my Tamil Nadu colleagues. It's like a homecoming to me. Have been trained, my internal medicine training from Coimbatore Medical College. So many of the faculty members from Coimbatore Medical College were Tamilians. So it's just like another sharing of my experience with my former colleagues. So I'm talking about metabolic associated fatty liver disease today. It's a huge health problem across the globe, affecting more than 1/3 of the population. Sorry, it's not.
So click on the slides once with the help of your mouse or, yeah.
Right. This is my disclaimer. I have edited a journal issue recently, but there's no financial conflicts in interest. It's just like I'll try to use some of the material in the journal, which we have published recently while doing this talk. This picture always amazed me, the evolution of human beings from the great ape with stout body and pot belly and forward-leaning posture, which gradually evolved over millions of years, roughly about 500,000 ago, to the erect hunter-gatherer man with lean body and good muscles, with the erect backbones. However, over the past half century, what you can see, are we going back to the original ancestor? This is the problem with the obesity pandemic across the globe in relation to adverse lifestyle, including excess calorie intake from the fast food culture and the invention of computers a few decades ago, which made man mostly housebound or indoors without much physical activity and adverse eating habits. So obesity is associated with significant problems in every organ system in the body, as you can see from this schematic diagram. One of the common involvement is of the liver, resulting in non-alcoholic fatty liver disease, which involves steatosis to severe liver disease in the form of cirrhosis and hepatocellular carcinoma. We classify obesity according to the classical international definition based on BMI. Any BMI more than 30 is considered as obesity, and any BMI more than 40 is considered as severe obesity or class 3 obesity. However, for the Asian population, the cutoff is slightly low because of the excess adiposity, with more than 23 kilograms per meter squared as overweight, and more than 27.5 kilograms per meter squared as obesity. This is the global scenario, having significant proportion of obese individuals in the North America and some of the Middle Eastern countries. If you look at India, we have a very limited number of obese individuals as per the standard international definition, about 5 to 10% only. However, we have worse abdominal adiposity, which will increase the risk of metabolic associated diseases, including fatty liver. I'll give a brief case scenario about which the audience can think before we go to the discussion about it later. This is a story of a 34-year-old Keralite computer engineer presented with some vague upper abdominal findings, abdominal symptoms. He has significant family history with type 2 diabetes in both parents and has features of metabolic syndrome as evidenced by increased BMI, waist circumference, and abnormal liver functions, along with some abnormality of the lipid profile and HbA1c. Ultrasound abdomen for evaluation of liver dysfunction was done, which shows grade 1 fatty liver. How do we approach this kind of patients? That's the question we have to face on day-to-day basis in our diabetes clinical practice. as well as our endocrine clinical practice. I'll come to this case scenario later after the discussion of a few more slides. If you look at the epidemiology, metabolic associated fatty liver disease has affected more than 1/3 of the global population currently. If you look at the Indian scenario, about 23% of individuals are affected, and 58% of individuals with diabetes and 46% with prediabetes has fatty liver. A recent data from Kerala showed that the population, about 50% of the population is affected by fatty liver disease, based on a study from Trivandrum, and 33.6% of these individuals had diabetes. And alarmingly, 22.8% of these individuals had significant liver fibrosis, indicating the gravity of the situation. The terminology non-alcoholic fatty liver disease has been changed to the most updated terminology, metabolic associated fatty liver disease, in 2020, based on an international consensus conference with scientists from 22 countries, with the chairship of these 3 persons. There has been more than 1,000 publications in the recent 2.5 years with this new terminology, and more than 30 editorials and commentaries on the topic. Professor Jacob George is a Malayali from Kerala. He is based at the Store Liver Center in Australia. He is one of the pioneers of the new terminology, which is going to change the care of patients with metabolic associated fatty liver disease in the near future. Looking at the definition, previous definition of non-alcoholic fatty liver disease, anyone with more than 5% of liver cells involved with fatty deposition, without significant history of alcohol and other liver diseases, were considered as having MAFLD, whereas the new definition doesn't consider alcohol intake or other liver diseases. And there are 3 categories. Anyone with steatosis and overweight or obesity are classed as fatty liver, and anyone with the type 2 diabetes and steatosis are considered as having metabolic associated fatty liver disease. This is very important for the long-term outcome profile. Those with normal or lean body mass index, they should have additional 2 criteria in the form of increased waist circumference, hypertension, elevated triglycerides or low HDL, pre-diabetic state, or increased markers of insulin resistance, or elevated high sensitivity C-reactive protein more than 2 milligrams per liter. Even the ICD code may change in the near future based on the new terminology. This is another slide showing the differences. In MAFLD, we have exclusion criteria, viral hepatitis and alcohol intake, and it doesn't consider the metabolic dysfunction. It also, we cannot evaluate coexisting other liver disease in presence of steatosis, and requires a liver biopsy for diagnosis of non-alcoholic steatohepatitis, inflammation of the liver. Whereas in MAFLD, we have additional inclusion criteria such as overweight and obesity, type 2 diabetes, and metabolic syndrome, plus or minus additional liver disorders. Importance of this is a homogeneous, homogeneous in respect of metabolic dysfunction, independent of other liver disease and drinking habit, and doesn't require liver biopsy for diagnosis of NASH or MASH, metabolic associated steatohepatitis. This is another slide showing the differences, which you can go through later. If you look at the total population with steatosis, about 70 to 88% belong to the category of both NAFLD and MAFLD, whereas only 2 to 9% of patients with NAFLD will not have MAFLD. However, if you look at the MAFLD without NAFLD, without the criteria of NAFLD, you can see 15 to 25% has this new entity. So it is probably a better classification to look at the long-term metabolic connotations of this particular disorder. And you have to bear in mind that there's a pre-MAFLD state with surreptitious ethanol intake or undiagnosed liver diseases. Distinction between MAFLD and dual etiology disease is also important because both are not the same. And in presence of additional risk factors, the metabolic dysfunction can be worse and it can be more tricky to manage those patients. The pathobiology of MAFLD is well characterized now, with adipocyte insulin resistance as the basic pathogenic mechanism, which increases release of free fatty acids into the circulation, which causes lipotoxicity when it is taken by the liver. This lipotoxicity causes endoplasmic reticulum stress, causing reactive oxygen species generation, resulting in hepatocellular injury, immune activation, inflammation, which worsens hepatocyte insulin resistance in a vicious circle, in turn causing gradual inflammation and disease of the liver, causing fibrosis, development of cirrhosis, and hepatocellular carcinoma. Various genetic and epigenetic factors, infections, lack of physical activity, all those things may contribute, and gut dysbiosis and altered bile acid secretion from the liver can also perpetuate the disease, in turn causing problems in these organs. There are a lot of non-risk factors, and there are a lot of associations of metabolic associated fatty liver disease, like high fat diet, high calorie diet, genetic and epigenetic alterations, as I mentioned, and gut dysbiosis, which can worsen the disease process, gradually developing cirrhosis and hepatocellular carcinoma. Insulin resistance and diabetes can worsen the situation, and patients can develop sarcopenia, worsening of lipid disorders, and vice versa. Various hormonal disorders like PCOS. Many of these patients may have sleep apnea, and MAFLD as such increase the cardiovascular risk. MAFLD has to be treated as a continuum of disease from childhood to late age. All depends on the steatosis in liver. And in children, the criteria is slightly different compared to the adults. And anyone with excess adiposity and steatosis in childhood should be considered as having MAFLD. Healthy weight, as in the adult with the normal weight or lean weight, it's similar. There are some additional criteria required to diagnose MAFLD in children. But if someone has prediabetes or diabetes in childhood and steatosis, they are straight away having MAFLD. Looking at the global scenario, you can see that according to WHO, in 2020, about 40 million children were obese or overweight in year 2020, whereas 340 million children between the age of 5 to 19 years were either overweight or obese in 2016. This significantly increased the risk of MAFLD, and you can see in Asia, about 52% of obese children has MAFLD. And South America and Europe follows us. There's an alarming rise in the global prevalence of childhood MAFLD, especially in the developing world, with the figures almost double from 1990 to 2017. There can be various gene polymorphism in children which predispose them to develop MAFLD and steatohepatitis. This slide was provided by my Cleveland Clinic colleagues to the journal issue I edited. And if you see the global scenario, MAFLD is with the maximum prevalence in the South American continent, with around 1/4 of the population involved among children. However, if you look at the MAFLD in obese children, it's maximum in Asia, with the prevalence of 46%. Prevalence figures are almost comparable in the North American continent because of the obesity pandemic among children. There's a proportion of patients who can be having healthy body weight with the low or normal body mass index, but they have metabolic dysregulation in relation to abdominal adiposity or diabetes. And in the MAFLD population, if you look at the prevalence of lean MAFLD. About 20% has lean MAFLD, whereas in the general population, about 5% of patients have MAFLD in the general population. Unfortunately, the lean MAFLD is associated with higher metabolic as well as extrahepatic and cardiovascular risk factors, which will come later. Lean MAFLD may be related to sedentary lifestyle, genetic alterations, and dietary indiscretion, which tremendously increase the risk of various disorders in each organ system, as you can see from the slide, including raised risk of malignancies. Dyslipidemia is a common association in patients with MAFLD, and both primary and secondary dyslipidemias can increase the risk of MAFLD, and vice versa, because if you don't control MAFLD, the liver will produce a lot of chemicals which will worsen the dyslipidemia, as you can see from the latest slide. In this picture, excess dietary fat intake will cause damage to the liver, ectopic liver fat accumulation, resulting in steatosis and mitochondrial dysfunction, which results in secretion of various lipid analogs, increase in the risk of dyslipidemia and cardiovascular health, and this in turn worsen the fatty liver disease. If you look at the cardiovascular risk, the hazards ratio for overall CV risk is 1.5 in patients with MAFLD. It increases steadily with the stages of MAFLD. For example, steatosis patients have a HR of 1.74, whereas those with the cirrhosis have a HR for cardiovascular disease with a figure of 2.6. So rigorous cardiovascular risk reduction is important in such patients. If you look at the mortality risk, patients with MAFLD and type 2 diabetes will have 2 times higher risk of death compared to a normal person, whereas cardiovascular risk is 2.35 times higher, and cancer-related mortality also is much higher in this population. If you compare MAFLD in overweight and obese and the lean MAFLD, you can see lean MAFLD population will have higher risk of all-cause mortality, cardiovascular mortality, and especially the cancer-related mortality with the HR of 1.54. Diabetes is a common risk factor for MAFLD, and about 55% of population with the diabetes will have MAFLD. These figures are given by my Indian colleagues, Professor Kaltra and Professor Kapoor from North India and Vellore. And you can see steatosis is significantly higher in patients with type 2 diabetes mellitus, and advanced fibrosis is not uncommon. Therefore, we have to expect about 1.4 million cardiovascular-related deaths and 81,200 liver-related deaths in the next 2 decades because of this dangerous coexistence. Therefore, any patient with diabetes, you have to rigorously manage them to improve the fatty liver disease. This is a schematic diagram showing the interlink between fatty liver and diabetes. You can see the common mechanism in pathogenesis of both, and both diseases perpetuates the disease in the other organ. For example, diabetes worsen fatty liver and fatty liver worsen diabetes. And if you look at the prevalence of fibrosis among lean fatty liver disease with the diabetes, you can see the risk is 4.3 times higher, whereas advanced fibrosis in patients with lean fatty liver and diabetes, the risk is about 14 times higher. Gut microbiome has been an area of immense research interest in the recent few years, and it is seen that gut dysbiosis is associated with significant worsening of fatty liver disease because of the production of various liver-related factors, which causes systemic metabolic dysregulation. Moreover, patients with fatty liver disease will have abnormal hepatobiliary circulation, that increases or worsens the gut dysbiosis, in turn causing worsening of the fatty liver in a vicious circle. Another important problem is sarcopenia in patients with the MAFLD. About 20% of patients with steatosis will have sarcopenia of some degree. And in cirrhosis, it can be worse. And early screening for sarcopenia is important for optimal care of patients with metabolic-associated fatty liver disease, because both diseases can worsen the insulin resistance. For example, fatty liver can increase insulin resistance, and muscle dysfunction can increase insulin resistance, which in turn causes lipolysis, worsening fatty liver, and fatty liver produces a lot of chemical factors which can damage the muscle, with worsening of the muscle function, with reduction of physical activity, worsening insulin resistance, all these things in vicious circles, perpetuating each other. Sleep apnea is another common association, and in patients with steatosis, 80% will have severe sleep apnea. And vice versa, 46% of patients in non-obese category and 68% of obese children with sleep apnea will have MAFLD. And fibrosis is higher in patients with sleep apnea. Therefore, management of obesity and obstructive sleep apnea may improve MAFLD-related outcomes. Because of the commonality in the pathophysiology and pathobiology, many patients, especially many females with MAFLD, will have PCOS. The odds ratio is 2.3 to 3.3 in patients to have this coexisting disorders. Therefore, any patient with PCOS and BMI of more than 25 kilograms per meter squared should be screened for MAFLD also, because management of metabolic dysregulation improves both the disorders. As we all know, pregnancy is associated with significant biochemical and hormonal changes in the mother, and any patients with fatty liver disease can have worse outcomes during pregnancy, and it can also affect the pregnancy outcomes, including worsening of the liver function and problems with the child. In the peripartum state, if the pregnant mother after delivery breastfeeds, it reduces the risk of fatty liver in the mother as well as the offspring, whereas formula feed can worsen the disease. Therefore, we have to consider as a disease spectrum in case of patients with MAFLD, about 25 to 35% of people involved with MAFLD, the steatosis, of whom 10% will have NASH or non-alcoholic or metabolic-associated steatohepatitis, 40% of whom will go on to fibrosis, and these patients, 5% will develop cirrhosis, and 7.5% of cirrhotics with fatty liver will develop hepatocellular carcinoma. We have to bear in mind there's no need for development of cirrhosis to develop hepatocellular carcinoma, because fibrosis as such is a risk factor for development of HCC in these patients. Looking at the pattern of fibrosis at different stages, if somebody has type 2 diabetes, that increases the risk of fibrosis about 20% higher compared to a patient in the normal category. Mortality risk also similarly increase, and if you look at the mortality figures, metabolic-associated fatty liver disease has highest mortality, all-cause, cardiovascular, and cancer-related mortality. Coming to the management of this enigmatic disease, because it is a disease related to our adverse lifestyle, basic treatment strategy, as in case of type 2 diabetes, is changes in the dietary habits and regular physical activity interventions. If these do not work, and when the patient has associated comorbidities, you have to consider pharmacotherapy in such patients. If that doesn't work, and with the significant obesity and comorbidities, we have to consider even bariatric procedures. We have to bear in mind that energy regulation in the body and weight problem is in relation to energy intake and energy expenditure, as you can see from the figure. Therefore, Obesity and obesity-related metabolic disorders are part of an abnormal energy imbalance. If you consume normal amount of energy required for the body and do exercise, you don't develop obesity. Whereas if you consume extra calories and have physical inactivity, it will result in obesity and metabolic disorders. Consuming an extra 115 calories a day, over a month, you will be consuming around 3,500 extra calories, means 1 pound of stored fat. Mainly dietary management involves various dietary patterns. There's no clear MAFLD specific diet, but we have to avoid excessive intake of high-calorie items and red meat and processed food. The best evidence is for Mediterranean diet and hypocaloric diet, aiming weight loss with a calorie intake of less than 1,500 in a female and around 1,800 in a male. It can be different for different populations as well. Intermittent fasting has been evolved as an important treatment option for many metabolic disorders and obesity, and can be tried in patients with fatty liver disease. I'm not going to the details of that because most of you diabetologists and endocrinologists knows about it. This is an exercise program I have developed recently for patients with some stretching activity of your muscles and joints. There's a YouTube video. I think it will, for the sake of time, I'm not going to the YouTube video. You can see that later. Physical activity recommended by most professional bodies in a week will help us to spend around 1,100 calories based on 150 minutes of moderate intense walking and 2 sessions of strength training. However, if you consume 2 full cups of coffee with sugar and milk, that will be neutralized. Even then, exercise will help patients with metabolic disorders. Therefore, we have to always combine physical activity interventions along with dietary changes to improve metabolic associated fatty liver disease and obesity. This is a schematic diagram of various medications which can be used in fatty liver disease. I'm not going to the details of that according to the organ of the action of these medications. Again, obesity pharmacotherapy should help patients with the fatty liver as it improves obesity, but you have to bear in mind the significant side effects. We have some new molecules in horizon. Semaglutide is already licensed for use for management of obesity with significant improvement of the obesity outcomes. And the tirzepatide, the report has been published last year with significant improvement of the obesity-related outcomes, and naturally it will be expected to improve fatty liver outcomes as well. So we have to consider this pharmacotherapy in our obese individuals. We have to always bear in mind that all the pharmacotherapeutic interventions should be coupled with intense lifestyle interventions such as physical activity and dietary changes, as we do in our day-to-day practice of treating type 2 diabetes mellitus. Any patients with dyslipidemia and fatty liver disease, dual lipid panel, and if they have increased LDL cholesterol, you have to treat them with statin. And if it is not working or if there are side effects, you have to consider other medications, including PCSK9 inhibitors. Endobarrier therapy has been evolved as a good treatment option for patients with obesity. And there's a recent report which shows improvement of the fatty liver outcomes as well. And if none of the interventions work, we refer patients for bariatric surgery, which is also a significant improvement of fatty liver disease as well in a subpopulation of bariatric patients who had later evaluation to look at the fatty liver outcomes. Any management plan for medical therapy for obesity will improve the outcomes by reduction of obesity to a maximum of around 20%. Of course, I didn't consider the newer pharmacotherapeutic interventions with the semaglutide and tirzepatide and a lot of new molecules. Even yesterday's New England Journal had a few new molecules in Horizon in the phase 1 and phase 2 trials. In such situations, we have to consider bariatric referral for our patients. Coming back to the case scenario, the 34-year-old Keralite male computer engineer with upper GI symptoms, with significant family history of diabetes, having mild obesity, increased waist circumference, metabolic dysregulation, and pre-diabetic state, with some changes suggestive of steatohepatitis and grade 1 fatty liver. How will you approach this patient? I think we can discuss that in detail during the discussion session. I'll go to the answer. In an ideal situation, because it doesn't qualify for any of the pharmacotherapeutic interventions, so we have to consider intense lifestyle changes, aiming to lose about 10% of body weight in 2 to 3 years' time, which should improve his metabolic dysregulation, although we have to be optimistic about the compliance. And this will improve the cardiovascular risk factors and metabolic dysfunction. I think that's the last slide for me. So concluding, obesity has become a global pandemic. We have to ensure that we have all the risk related to obesity pandemic, including fatty liver disease. Treatment is mainly lifestyle changes, and if they do not work, we have to even consider pharmacotherapeutic interventions and bariatric surgery, though these are not recommended by any professional bodies at the moment. The only option is to give lifestyle interventions. But as diabetologists, we will be forced to use judiciously the appropriate medication to improve their diabetes, which should also improve the fatty liver disease and the outcomes related to liver-related problems. Thank you, and I welcome your thoughts on this subject so that I can also learn something from you.
Thank you very much. I mean, obviously, it's sort of the hot and happening topic, and being diabetologists, we see fatty liver, I think pretty much, I think it's 100%, pretty much, so, of all of our diabetic patients. My question was, I mean, a lot of the papers refer to assessing risk for fibrosis, progression of fibrosis using like the FIB-4 score and other scores like that. What is your opinion? Yeah, I mean, first tell me your opinion, and then I'll share some data that we looked at our diabetic patients. So,
yeah, in fact, after the new terminology, that's one of the advantages of this new terminology, metabolic associated fatty liver disease. You don't need to do liver biopsy for diagnosis of fatty liver anymore, of course, because it's a procedure associated with serious risk of bleeding and complications. So there's no clear indication for, unless there's a gross doubt, you don't need to do biopsy in these patients. So fibrosis 4 score and other fatty liver scores, NASH score, and a lot of scores are there. They're all useful for characterization of the disease process, as well as prognostication and monitoring of these patients. So liver biopsy is rarely done by most of these patients. And if we have a suspicion, the latest addition is the velocity-controlled fibroscan, which will give a good indication of the degree of involvement of these patients. So that'll be very useful investigation to assess and monitor the patients. So mostly we don't do the biopsy, except in rare situation where, or sometimes when you do the bariatric procedure, you can do the biopsy to stage the liver disease and then possibly to monitor and follow. Because anyway, you are going to do an endoscopic procedure, and you can do the simultaneous liver biopsy during bariatric surgery. Otherwise, rarely we do bariatric liver biopsy these days. And of course, I'll be very happy to, very keen to see your data because we don't have a routine fatty liver clinic in our endocrinology practice here. Mostly it is done by the hepatologists. So if you have good data, that will be very helpful. I also have my data with the diabetes patients looking at various outcomes, and many of the patients have MAFLD as an association.
Yeah, so the question I had was really because if you look at the international guidelines, they say use a FIB-4 score of 1.3 as a cutoff. And if it's higher than that, I don't know, then they have an intermediate, but below 1.3 is considered low risk. And when I looked at our clinic diabetic patients, the average score was higher than in the non-diabetic, but well below the cutoff. So I was just wondering, is there, I think we need to start looking at like how we have different cutoffs for waist circumference for Indians. I think we need to start looking at different FIB-4 scores, maybe, for Indians.
Yeah, Indians, the cutoff is already there. It should be less than 88 for the Indian males. But I think we have to even revise that, because the Physicians Association of India in 2009 take the BMI cutoff 25. So our abdominal adiposity is much worse. So we should have some good data to revise the definitions. That's a good point. Yeah.
I think cutoff of 23 and 80 and 90 centimeters, exactly what you had said, 80 for women for waist circumference and 90 centimeters. And I think we're using that. But I was wondering about the FIB-4 scores, because at least as far as I know, I don't think we have any criteria, but it'll be something interesting to explore, I suppose.
Yeah, I don't think we have a current definition for the Indian population or the Asian population. So we'll have to probably look into that seriously, because that's one of the important prognostic factors we have to look into in future.
Thank you.
There should definitely be a genetic component, because you have certain individuals who progress on to symptomatic disease while others do not.
Yeah, multiple gene polymorphism has been identified. Some of them I don't even remember, but in one of the slides I've shown that the PLNP polymorphisms and other polymorphisms. So there are several genetic polymorphisms which may increase the risk, but again, it's not a very clear association. I don't think there's a criteria for screening those kind of individuals or screening for those gene polymorphisms. This is all based on some of the studies from different populations, like Netherlands. They have done some studies. One of my authors from Netherlands, they have done some risk association between this gene polymorphism and cardiovascular risk and all. But I don't think there's a clear consensus on those gene polymorphisms and whether we have to look for those in some of the individuals. I think our population may have a different genetic composition which increases the risk. For example, I was talking to one of my close friends. He's quite lean, but he has stage 1 fatty liver disease with a strong family history. All the family members have diabetes with very lean habits. I had to stop metformin in those people because they have been already lean. So I didn't want them to have more wasting of their muscles. But they have fatty liver disease, and it's difficult to manage also, because you don't have anything to lose from the adiposity side of things. But still they have disease. But I would think still dietary changes as well as exercise should help them to some extent at least.
What is the choice of drug which you would use?
For isolated fatty liver disease, we can't use anything currently because of the licensing problems. But if somebody has diabetes, I straight away go for, especially if they have obesity, I straight away go for things like semaglutide, which I have a good data with significant weight loss in many of the patients. Of course, metformin as the first line for diabetes management, and the second line, possibly a GLP-1 agonist, I will consider in such patients. Advanced stages of liver disease, usually the hepatologists take care of them. I don't think they started using obeticholic acid and adafulmin here with most of our usual patients, except in the research settings. But first line is always in a diabetes practice, metformin. I think the recent ADA last week, they were mentioning about pioglitazone as well as GLP-1 analogs for patients with diabetes and fatty liver disease. So that's a very good addition from the recent conference. But we have very good experience with the GLP-1 analogs. The problem is there's a global shortage now. We struggle to get the semaglutide these days. Even the oral varieties, oral molecule is short. So we had to switch over some of the patients to different molecules. But semaglutide has a very good benefit after metformin in diabetes and patients with fatty liver disease. I always go for semaglutide. Of course, pioglitazone rarely I use these days. And if patients are not willing for GLP-1 analogs, the next option for diabetes and fatty liver is probably DPP-4 inhibitors as well as SGLT2 inhibitors. There are some data showing benefit of SGLT2 inhibitors as well, but not routinely recommended by any of the professional bodies now.
Dual.
No, go ahead.
In India, we have the dual PPAR, alpha gamma agonist has been cleared and the thing approved.
Yeah, the glitazars. Yeah. I don't think we have enough of experience with that molecule here. We don't routinely use the glitazars here. I think that's a quite reassuring new molecule and possibly useful in fatty liver disease because that alters the pathobiological mechanism as well. So that should be really good. I don't have experience with those molecules here.
Thank you very much, Dr. Joseph. After a bit of a
struggle initially.
Yeah, thank you very much for sharing your experience with us. And thank you for coming and talking at Trendo and hoping to see you in person soon.
Thank you so much.
Thank you. I'll be attending the national conference in December, so we can all meet up there. Thank you.
Wonderful.
Bye-bye.
Wonderful. Thank you.
Thank
Bye-bye.
you.